Greetings, this is the Documentation 101, revised February 2016 for Andrew County Ambulance District. This is actually part 2 of 2. The first part is called Patient Care 101. If you have not watched that video, please stop this video and watch that video first. Then come back and finish this video. When we talk about this presentation, I talk about the patient report template. This presentation will be based on that patient care report template in the AIM/RAM system that we use here at Andrew County. Although this is only highly suggested to be used, the concepts listed here are mandatory to be included in the narrative section of all the reports that are written. I do want to get this out of the way. This is something that's always brought up whenever documentation, and especially about narrative documentation, is brought up. I know the blue instruction booklet for the state of Missouri specifically stated that you should not repeat items on the state report. I also say that this instruction booklet was written as the instruction book for the paper reports that were written, I can't even tell you how many years ago. So this is old thinking. This is old ways of doing it. The simple way to look at it today is your employer has designated certain criteria for narratives. It is a requirement of your job. I am sorry to be harsh about it, but the argument has to be laid to rest. It cannot keep coming back over and over. Well, I was told that you should do this, or I don't like to do this. Well, it doesn't matter what you like about this situation. It has to be done. We're going to take each section of the template and we're going to break it apart and give examples of what should be in those sections. If for some reason you don't use the template, it may be difficult to include all the needed items that are required, but they are required. So, but the one thing that is required is breaking up the narrative into manageable chunks. So it's not just one big paragraph for the whole narrative. It needs to be broken up where it's readable, and it must contain the information that's listed on these slides. The initial section on the template is the dispatch section. You need to put what you were dispatched for and how you responded. 805 dispatched for chest pains, responded emergency lights and sirens. Simple. C, this is what you found upon arrival. Where the patient was sitting, the position they were in, the level of distress. 805 arrived, found patient sitting at the kitchen chair in a tripod position, having severe shortness of breath. History of present illness or injury. In this section, generally the chief complaint is listed, any associated complaints, and then why did they call the ambulance? What led up to? Not just, oh, they're having shortness of breath. We want to know how long they've been having shortness of breath. Have they done anything about the shortness of breath? Have they taken any breathing treatments? Have they had this before? Have they had to call the ambulance before? Have they had to been intubated for the shortness of breath? What kind of medical history do they have? All this goes into the history and building the story of why they called that ambulance. So why did they call the ambulance? The details about why they called you. What did they do for it? Any history? And this is an excellent place to put your sample history. Primary assessment. This is a general section where usually just a quick level of consciousness, level of orientation is listed. Maybe an airway status, especially if it's not patent. Their level of breathing, how they're breathing is, their skin color, temperature, moisture, any bleeding or circulation issues. Just a quick general overview of that primary assessment that you do on the patient. This is the head, the eyes. Obviously, pearl is always a good thing to, or pupils are a good thing to put here. Ears, nose, throat. Chest, back, lung sounds. Chest pain description. If somebody's having chest pain, this would definitely be a good spot to put where that chest pain is, where it radiates, what it feels like. Does it get any better? The severity. Three other sections, the abdomen, pelvis, and extremities, are all pretty well self-explanatory. Any of those that have any issues definitely need to be going in depth with the pertinent negatives and the pertinent findings. A new section I added was the diagnostics section. Most people were putting this in the treatment, and I think this got confusing a lot of times because even Dr. Davis said she couldn't discern between what was maybe a treatment and what was just the diagnostic, and it did get confusing at times. So I broke this into a new section. So this is where your 4, 12, 15 lead EKGs are listed and their interpretations. If you take a blood sugar, this would be the place to list it. End-tidal CO2, capnography waveforms, other things like if you do orthostatics, maybe your SaO2 would be good in this area. Anything that's not just a general assessment that doesn't really fit. Now, obviously, if you want to put the 4 lead, 12 lead, 15 lead EKG under the chest area, that's totally appropriate. Doesn't have to be. I just put this section in to kind of break out the treatments from just the diagnostics. Which brings us to the treatments. What were the treatments that you did? What were the results of the treatments that you did? This is a big area. We see a lot of problems on the QA side of just not getting an in-depth information. It's like gave albuterol treatment for breathing problem. Well, that really doesn't give us much information about what the breathing problem was, what's going on with that patient, and then the result. Did they get better? And not just breathing improve. Well, how did it improve? Did the SaO2 get higher? Did the capnography go down? Did the waveforms on the capnography change? These are things. Did their skin dry up? Did they start breathing slower? These are things. These are in-depth pictures that you need to paint when you read your narratives. Also, movement to the stretcher, transport, and possibly orders. It's a good place to kind of put this. Under the conclusion, this is a good spot to put your transport to the ED. Maybe your transfer to your nurse, your transfer to your ED bed, your method move there. Any changes in the patient, and then any other closing remarks that you normally maybe put in there. Transport reason. This is the very last little section, and what this is designed for is a very simple, clear, concise reason that you transport in the hospital. The point of this is the billers are able to just kind of look through, skim, and then all the way down at the bottom, after they read quickly through the narrative, that they see the transport reason is the same basic picture that you painted. And we do this on the QA side too. Does the picture that's read match that transport decision? It doesn't have to be a full paragraph. It just needs to be, if it's chest pain for the reason, it's chest pain. That's all it has to be. It doesn't have to be chest pain to rule out MI, to have cutaneous interventions. It doesn't have to get that in depth. The reason they're being transported, simple chest pain. Some other thoughts. Blood sugar. Any ALOC, altered level of consciousness, has to have a blood sugar per the protocol. Document this number, this value, in your narrative. Blood sugar equals 136 milligrams per deciliter. It does not take that long. The person reading the narrative sees an altered level of consciousness, should not have to look through the other 4, 5, 6 pages of the narrative to find the blood sugar. It should be in the narrative, easy to find, quick to find. And it is a requirement of the protocols. Pain scale. If you say they have pain somewhere, there needs to be a pain scale in the narrative. If you gave a pain medicine or other treatment for that pain, give another pain scale. So if you say that initially they're having chest pain rated 10 out of 10, gave 1 nitro, it dropped it to a 7 out of 10. Gave 2 milligrams of morphine, it dropped it to a 4 out of 10. There needs a progression, and a following. The pain scale is only used well if it's used against itself at another time. My pain scale and your pain scale are going to be 2 totally different things. You could have chest pain, and you might say it's a 2. I might have chest pain that it's the same amount of chest pain, and because I'm a wuss, I might be a 10 out of 10. So, but then if I say, oh wow, it's really gone down. It's down to 5, that's half the pain. Same way if you're 2 and you say, well, it's down to 1 now, that's still half the pain. So pain scale is relative, and it's only good if you use it against itself. Dyspnea. This is a big one I see a lot. We do not document dyspnea very well at all. We say patient short of breath. Maybe their lung sounds have some wheezing in it, but that's it. Sometimes we get the speech. Capnography is not used nearly enough, especially on dyspnea patients. If they're short of breath and they're having breathing problems, they need to have capnography. They need to have the end tidal documented and the waveform documented. And then other general signs of respiratory distress. Were they in a tripod position? Were their speech short, one-word sentences? Were they using accessory muscles? Were they abdominal breathing? Did they have pursed lips? Were they cyanotic? Did they have delayed cap refill? There's many ways. Pale, cool, clammy skin, diaphoretic. So many ways we could be describing dyspnea, and not just describing the initial dyspnea, but after the breathing treatment. What do they look like? Are they better now? Are they breathing better? Are they speaking more clear? Is their cyanosis going away? Are they using less accessory muscles? We need to be describing these things better. This is the opportunity to use your skills of not only patient care, but also description of that patient care to show you really know what you're doing with those patients. Some miscellaneous issues, refusals. Aside from the fact that we need to remember it is our job to transport patients, not to obtain refusals. When we read reports, there are reports that indicate to me that people are talking people into refusals, and that should never happen. This may be very soon followed up with the patients themselves, and getting somebody to refuse care is a liability to not only the ambulance district, but to your license. It is our job to get them to go. Same way with offering them advice, advising them not to go, or advising them that they really shouldn't go, or advising them that it's okay to stay home, or that maybe they should do this. These are not things that we should be doing alone, documenting them. They should just not be done. It's our job to go pick them up, take them to the hospital. We're not doctors. We're not nurse practitioners. We're not nurses. Well, we have one nurse, but that doesn't count. When you're on the ambulance, you're a paramedic. It is the job of us to take them to the hospital. Canceled en routes, we need to know. Oh, back on the refusals, I'm sorry. We also need to know, we need to make sure that we document at least 2 attempts, preferably 3 attempts, to get them to go to the hospital. Make sure we document that we told them that we'd come back if they needed us to. Document what you think they're doing. Are they staying home? Are they going to follow up with their doctor? Are they taking their private vehicle? Tell us as much as you can to let them know that we did everything we could to resolve any problems that that patient had. Canceling routes, the only big thing I have there is we need to know exactly who canceled us. Find out from the dispatch who canceled us. That needs to be in the documentation. A third person, if there's a third person rider, full name of that person. If there's people on the scene, we need to know who's on the scene, not just first responders. We need to know who those first responders are. We need to know who to contact if there's a communicable disease. We have that responsibility to protect our first responders. Also best if you could find out who the police are. If you know who they are, put their badge number, put their name on there. If you can't, at least put the agency. Don't just put police on the scene, put it on Andrew County Sheriff, Savannah PD, Country Club PD, whatever it may be. That falls under the additional units. Also, noting in the narratives, which doesn't happen a lot, I have to go to the other form, which is not going to get uploaded with somebody requests it. Note the STEMI of the trauma and the stroke alerts. Note the times. Note who you talk to. A lot of times I'll get a report back not notified by EMS. And of course EMS says, well, we did, but we don't know who we told. Tell us who we told. If you do call the ER for some reason, you definitely need to find out what line you called in on and who you talked to on these, because if we need to follow up with, it's nearly impossible to find that out. Please always remember that documenting the call is just as important as running the call. I know people don't feel that way, but it is true. It is important. Just as checking your truck is a pre-run, then you have the run, and then you have the post-run. The post-run is the documentation. This is a document that's going to be with the patient for many years to come, potentially. That could be looked up. That could be requested for up to 5 years from us. So this could be around for a long time. Your documentation is a direct reflection of your patient care. You might be the greatest person that gives the greatest patient care, but when you don't write it in your narratives, people are not going to look at it that way. The people that read your narratives, the billers, the medical director, the supervisors that do your QA, are not going to have that strong feeling that you have excellent patient care when you're not taking the time and the thoroughness in your documentation. It does reflect your patient care. And that narrative could be someday in front of 12 jurors trying to decide whether you provided gross negligence or not. Do you want to take the chance that because you're tired or you want to get home early or you want to do whatever, you want to get back to watching TV, that you took an extra 10-minute shortcut and didn't provide the best patient care you possibly could? Take the time to do it. Final thoughts: failure to document correctly may result in the form being returned to you to correct. When this does happen, it is not appropriate to get mad or argue with billing staff or supervisors when this happens. They are responding to my direct orders to send certain things back to the staff. If the billing department sends something to you or says something to you, it just needs to be fixed. If you have issues with why you're fixing something or what's being told to you, I will be more than happy to visit with you about it, and we can discuss it. They just need to get done and corrected. They're only following what my orders are to them. Everybody has a job to do. They're just doing theirs. I will say the documentation is beyond improved. I looked at some of the reports from the first days when we had the AIM report 140168 and 169 and 17, and the little tiny short narratives are fairly gone. We're doing better. I'm not saying that it's not improved. Overall, everybody has made efforts and is doing a good job. But that doesn't mean we have to rest on our laurels and say, okay, well, now we'll stop doing QA and we're going to stop doing this. We still see stuff on a daily basis. We're still going to send back to you stuff via the QA method. We're still going to visit with you once in a while when we have questions about things. So it is improved. I thank everybody for the efforts that they have made already. But there's always room to be improved more. Thank you for taking the time to listen to this documentation video. I know it's a boring subject. I know it's a subject that I have repeatedly harped on many, many, many times, but it is an important subject that we need to make sure we get right. So thank you very much.